Patientcentered Hospital is an acute hospital in Stockholm, in the Stockholm area. It's the only privately owned but publicly funded acute hospital in Sweden. And we are one of 4 emergency hospitals in the Stockholm local area. And we are in Stockholm, we are one of the smaller hospitals, but compared to the rest of Sweden, this is a big emergency hospital. We have 85,000 emergency visits every year. We have 2,000 employees, 322 beds, 8 intensive care beds, 30,000 inpatients every year, and a couple of 100,000 outpatient visits. And we collaborate very closely with the county, as we are privately owned but publicly funded, so all our patients are from the county. Patients in Stockholm can go to any of the emergency hospitals in the Stockholm area. We collaborate very closely with the other hospitals. Stockholm is in a transition period of how to perform healthcare, as Stockholm is a growing area and we are building a new university hospital that is slightly smaller than the present one. So I meet with the county director and all the other CEOs of the hospital every other week to have discussions about how to give care. And we also compare our quality results. Quality indicators are very important in the assessment of healthcare. To be able to improve and to give the best possible care, you have to measure what you deliver. To be able to improve healthcare, we have to know the quality of the care we provide. And to be able to do that, we have to measure things. And in Sweden, we have a lot of national registers where we put in data about our patients, and that gives us a possibility to be able to compare us with other caregivers, but also to compare us with ourselves, so we can work with continuous improvement, which is our basic strategy. We want always to be better tomorrow than yesterday. So we measure a lot. It's also that we have won the contract to provide the care at Patientcentered Hospital in a tender process where we have set goals, quality goals, that we report to the county yearly. We have the indicators that we measure are in all our bigger patient groups. They are specific for each patient group. For instance, if you get the hip implant, we have to know that the hip implant doesn't get infected, that you can walk well with the hip implant. So we set clear outcome goals that we measure. But on the way to the outcome goal, we measure process goals as well. And the county also compares process goals between the different hospitals. For instance, door-to-door time in the emergency room, the time it takes for an old patient with a hip fracture before they are operated. So we measure both outcome, we set clear outcome goals, and also we make care programs where we measure process along the care program. When I talk about outcome measures, that's only qualitative. It's clinically reported outcome, patient-reported outcome, and patient experience. Then we also measure process goals, and that's more how long time different things takes. And waiting times, etc. Exactly. Yes, we work a lot with patient feedbacks. We have one national inquiry for patients once a year that we do in all the hospitals, but we want to measure our patients more often. So in different wards we measure. Now we have a pilot where we measure every patient with an iPad before they leave the visit. That's something we measure. We have a project now because we think once a year is too seldom. We want to measure all our patients. So now we are testing how to perform that. So in 4 or 5 wards, we ask all patients before they leave how they have experienced the visit. But there are also questions about their health, not in those everyday surveys, but in our quality registers. It's both that we report what we have done and the result, but we also ask patients there to report how they feel. Hospital environment, of course, is good to provide health care, but it's a dangerous area to be. So, of course, it's better if you get healthy quicker for patients, and that's both better for the patient, who gets to stay shorter time in our surroundings, but it's also good for the whole healthcare system because we can provide care cheaper. So we have been working a lot in Sweden and in this hospital with ambulatory care. What has happened the last couple of years is that we have shifted that kind of care outside the emergency hospital because you don't need our base to have. So the proportion of ambulatory care in the hospital has been growing, but as soon as it gets to be ambulatory, it can be performed outside the emergency hospital. But for instance, when I started here 25 years ago, if you operated a gallbladder, you would be in hospital for 5-6 days. Now you do it in 6 hours. Yeah. So there's been a big trend shift, and what we aim is to restore health as quick as possible, both in planned care and emergency care. So in emergency care, it's about how to get the diagnosis as quick as possible. So we have our radiology department inside our emergency department, so we can get quick assessment. Once you become an inpatient, it's important to have a very patient-centered pathway, so you can be in hospital as short as possible. We don't, as we shift them out of the hospital, I can't say the proportion because we get heavier and heavier patients instead. We work a lot with our patients. All this is driven by the physicians to get the short average length of stay, which is good for the patient, it's good for the hospital, and it's good for the society. Because when we make the average length of stay shorter, we can treat more patients in every bed. And the thing is not to send patients home earlier or too early, it's to make them healthy quicker. So it's a lot about having a well-informed patient before, and to do the right things before operations so they recover more quickly than before. So for hip implants, for instance, 4 or 5 years ago you could stay in hospital for 6 days. Now if you are a healthy person, you go home the next day. Our main strategy is that quality drives productivity. If you do the right thing with the right patients in the right time, you get a healthier patient quicker, you get high quality with less infections, for instance, and you get the use of the hospital's resources for more patients than before. Our resources have increased, but not as much as our patients have increased. So we have grown more in patients than in resources.